Hi, this is Argon Chen from National Taiwan University. Welcome to this section. In this section, I'm going to talk about upper airway ultrasonic assessment for OSA diagnosis and treatment. In today's talk, I'll first talk about upper airway imaging technologies and their problems. Then I'll introduce you an innovative 3D ultrasound imaging technology developed by AmCAD-UO in Taiwan. Using the technology, we have conducted studies at National Taiwan University to identify anatomic risk factors of OSA. I'll show you some results today. The technology can be also used as a companion diagnosis tool for OSA treatment. We have conducted studies at Stanford University. I'll share with you some preliminary results today. Finally, I will have some concluding remarks. As you know, obstructive sleep apnea is a growing problem. Undetected OSA can lead to serious problems such as cardiovascular problems, mental problems, or even death. The current standard diagnosis of OSA is polysonography, or so-called PSG. The cost of PSG is high, and there's always a long waiting list for sleep labs. Interpretation and scoring of the data are also labor-intensive. The study environment is different from home, and the subject has to be connected to many measurement instruments that may lead to failure of the study. Alternatively, you can choose home sleep test with some of its own problems as well. These tests are based on physiological measurements. Pharyngeal airway imaging has been shown quite valuable to OSA diagnosis and treatment. The imaging modality of CT and MRI are considered scarce resources in the hospital with high cost. And the imaging are not as dynamic, and there are possible side effects of the contrast medium used for imaging. In the case of CT, you also have to be exposed to radiation. For patients with claustrophobia, they are not suitable. In contrast, ultrasound imaging has many advantages. Of course, there's no radiation exposure. It's completely safe. It's relatively inexpensive, and you can get it everywhere. The accessibility is high. It's dynamic, fast, and real-time, and it's considered very good in differentiating soft tissues. But there are also problems. Unlike CT MRI, for the ultrasound scan, it's very operator dependent. In other words, the operator has to hold the transducer to do the scan. The interpretation of the images is also quite subjective. In other words, it's very observer-dependent interpretation. To solve the problems, AmCAD-UO in Taiwan has developed a technology to standardize the ultrasound scan. First, they use robot arm to hold the ultrasound transducer, and then they project laser beams on the human head and neck to position the head and to position the transducer. For transducer positioning, they define a cross-section plane passing through hyoid bone and the ear opening called HM plane, so that they are able to aim the transducer along with this plane. Now let's take a close look at this HM plane. When you are aiming your transducer along with this HM plane, where exactly in the upper airway region you are looking at? On the right-hand side is an MR image, and you have a tongue right here. The HM plane is going through this region. So the cross-section of the MR image looks like this one. Again, you have the tongue, and you have an interface between the soft tissue and the airway space in red color right there. And when you scan your ultrasound, the ultrasound actually is covering this region. So the ultrasound image looks like this one. Again, you have the tongue, and then you have the interface between the soft tissue and the airspace in red color right there. After you acquire images from ultrasound scan, you can now use AmCAD-UO software to analyze the images. Here is the graphical user interface of the software. You can analyze two images simultaneously. For example, on the left-hand side, you have the image under normal breathing, and on the right-hand side, you have the image under monomaneuver. The software will identify the airspace automatically for you, and then show the airspace in red color. The software then calculate and analyze the airway width and depth, and the statistics will be shown at the lower right corner. In blue color, you can also compare the air column width side by side. In this case, you can see clearly that the airway width is much smaller on the monomaneuver. At the same time, you can also analyze the airway depth side by side. The technology also allows you to perform sector scan of the ultrasound to acquire multiple angle images of the upper airway. By turning the transducer like this, you can acquire sector images of the upper airway. On the MR images, you can see how the sector scan covers a segment of the upper airway. On the right-hand side, you will see the corresponding cross-section images of the upper airway. The ultrasound scan will cover a region like this, and the dynamic image of the ultrasound scan will look like this. Using the technology, we have conducted clinical studies at National Taiwan University Hospital to identify anatomic risk factors of OSA. The airspace is sometimes not visible on ultrasound images because of the anterior-posterior collapse or lateral contraction of the soft tissue, possibly caused by gravitation effect or monomaneuver. The researchers' aim is to study how the airway observability and the airway width changes at different levels of airway regions are related to the OSA severity. The study has included 112 OSA patients from consecutive referrals to sleep clinics of National Taiwan University Hospital from October 2017 to October 2019. 74% of them are men. The median HI is 24. The median age is 51, and the median BMI is 27. We have also included 16 healthy volunteers. 62% of them are men. The median HI is only 0.4. The median age is 33, and the median BMI is 22. We have excluded patients who are not able to perform monomaneuver and who have surgeries around their neck or pre-existing condition that may affect the study results. In this study, we performed 20-degree sector scan of ultrasound imaging to cover retroglossal, oropharyngeal, retropalatal areas of the upper airway. And then we use AmCAD-UO software to quantify the airway observability and the airway width changes. The study results show that there are significant correlations between AHI or DI and the airway width changes in all regions of the upper airway. There are also significant effects of the airspace observability in the retroglossal region of the upper airway under monomaneuver. The average AHI is 26 when the airspace is visible, but the AHI is 42 in average when the airspace is not visible. The similar results can be observed for ODI as well. Using the significant anatomic risk factors, we can build prediction model to evaluate the risk of moderate to severe OSA. That is, the risk of having HI greater than 15. The area on the ROC curve can reach 90%. When you choose a sensitivity of greater than 90%, the specificity can reach 62%. When you choose a specificity of 90%, then the sensitivity can be as high as 75%. With the promising study results, AmCAD-UO has integrated the ultrasound scanner, the laser alignment tool, and the AmCAD-UO software into one system to ensure a smooth workflow for the upper airway assessment. The integrated system extends the sector scan to 30 degrees now to cover the velum, oropharynx, tombas, and epiglottis regions of the upper airway. The system also offers 3D reconstruction of the upper airway, so that you are not only able to look at the transverse view of the upper airway, now you are also able to look at the sagittal view of the upper airway and the three-dimensional projection of the upper airway. On the graphical user interface of the AmCAD-UO analysis software, you can now analyze the 4 regions of the upper airway separately. You can also choose different views of the upper airway: transverse, sagittal, or three-dimensional projection. You can also synchronize the display of the upper airway regions for comparison study. For example, on the left-hand side, you have the airspace under tidal breathing, and on the right-hand side, you have the airspace under Mueller maneuver. And now you are able to compare them side by side and region to region. As you can see here, the airspace width is significantly different in the regions of velum, oropharynx, and tombas, but not as significant in the region of epiglottis. The technology can be also used as a companion diagnosis tool for OSA treatment. Conventionally, you probably will use transnasal fiberoptic endoscopy to look for the obstruction location in the upper airway. Or you can use drug-induced sedation to mimic sleep condition and to use the endoscopy to examine the patterns of collapse in different regions of the upper airway. Here is an example of transnasal endoscopy. This is a 44-year-old man with BMI 26, AHI 32, ODI 34, and lowest saturation of oxygen 56. The experiment was performed by Dr. Pharyngeal at Cathay General Hospital. As you can see here, the soft tissue collapsed in the regions of velum and oropharynx, but the airspace started opening up in the regions of tombas and the region of epiglottis. The same subject under DISE study and similar results can be observed. Again, in the regions of velum and oropharynx, you will see complete collapse of the soft tissue, and the airspace again started opening up in the tombas region and in the epiglottis region. How about ultrasound imaging? We performed the ultrasound scan on the same subject. And as you can see here under the Mueller maneuver, you don't see any airspace in the regions of velum and oropharynx. But the airspace started to appear in the region of tombas and epiglottis. We have also conducted studies at Stanford University. Here are some preliminary results I'd like to share with you. We have 26 cases here, with median age 33, median BMI 24, and median HI 14. On the left-hand side here, we compare the lateral pharyngeal wall collapsibility observed by Dr. Stanley Liu using nasal endoscopy, and the y-axis is the HI. And you can see a clear trend here where when you have a greater collapsibility in the lateral pharyngeal wall, then you will see also a higher HI. On the right-hand side, we compare the observation of the nasal endoscopy and the observation on the ultrasound image. So the y-axis here is the airspace contraction calculated by AmCAD-UO, and you can see a clear agreement between the two. Here is a study to compare the ultrasound images of upper airway, with or without wearing the oral appliance. The oral appliance here is off-the-shelf oral appliance. On the left-hand side is the molar maneuver without wearing oral appliance, and on the right-hand side, the molar maneuver is with oral appliance. And you can see the clear difference in the airspace width in the regions of velar, oropharynx, and thombus. But the difference is not as much in the epiglottis area. Here is another study to compare the ultrasound images of upper airway with tailor-made oral appliance. On the left-hand side is the molar maneuver without wearing oral appliance, and on the right-hand side is the molar maneuver with the tailor-made oral appliance. And as you can see the difference in airway width in all regions, even in the region of epiglottis. We also try to see if CPAD can make a difference on the ultrasound images of the upper airway. On the right-hand side is the 3D reconstruction images of the upper airway, and you can hardly see any airspace there. On the right-hand side, it's the airspace on the 5H part, and you can see some airspace is already opened up. And then we try to increase the CPAD pressure to 10H part and compare the difference between the 5H part and 10H part, and to see the effect on the airspace. And as you can see here, the airspace is further opened up under 10H part. Here are some concluding remarks. We first introduce a new technology to minimize the inter-operator variability of ultrasound imaging of the upper airway. The new technology uses a laser-assisted alignment tool to standardize the human head and to standardize the ultrasound scan. The new technology also uses a computer software to analyze the ultrasound images of the upper airway. Ultrasound imaging using this new technology can be used for possible OSA screening by quantifying the airway observability and the airspace contraction, and to evaluate the risk of moderate to severe OSA. The software also provides 3D reconstruction of the upper airway ultrasound images, so that VOTE for different regions of the upper airway can be analyzed separately, and it can be used as a possible companion diagnostic tool to increase the success rate of treatment options. This concludes my talk. Any questions will be welcome. Thank you.